in. But let me start with some brief announcements, and of course a welcome. Welcome back to the fall semester. This is our first HIV Center Grand Rounds since the summer and post Labor Day. So hope people had a good summer. And I think a lot of us will be seeing each other in person a lot more often. We still have a kind of a combination hybrid kind of thing going on for a lot of us. But anyway, glad you're here today. We have a very special event. A dear colleague is presenting to us. Let me start by telling you about our next Grand Rounds on September 30th. And if Stephen can, he'll put it up. Yeah, there it is. So on September 30th, we have one of our early stage investigator dual rounds. So we have two people when we do these things. And as you can see, we have Yusuf Ransom from Yale School of Public Health, another Yale LaRon. Social cohesion and social capital, their role in HIV prevention in the United States. And then the second billing on that day will be Tara McKay from Vanderbilt University, advancing social justice for LGBTQ populations in the global South through HIV research and policy. So please join us on September 30th. And then I'd like to give you a heads up on the, we're really excited about this, and congratulations to Teo Sanford, Stephen Sukumaran for making this happen. We will be having a series of our former fellows, postdoctoral fellows. So it's the postdoctoral fellow alumni rounds. And as you can see, they spread from October of 2021 through June of 2022. I'm not going to go through each of the names, but it is very exciting, and you know, a lot of it's very successful post-alum. And so we're looking forward to, over the course of the fall and the spring semester, of hearing from our former fellows at these Grand Rounds. Okay. So without further ado, let me introduce our speaker for today. Personally, it's I'm very pleased to be able to introduce LaRon Nelson, Dr. LaRon Nelson. And LaRon has more initials after his name in terms of degrees and titles. I think I counted 16 or 18. I'm not going to go through them all. LaRon Nelson is the Independence Foundation Associate Professor of Nursing. He's the Associate Dean of Global Affairs and Planetary Health and Associate Dean of Global Health and Equity at the School of Nursing at Yale University. He's co-director of the Research Education Initiative for Diverse Scholars Fellowship Program in the Yale Center, one of our sister centers in the Center for Interdisciplinary Research on AIDS. And in Canada also, Professor Nelson is the current holder of the OHTN Research Chair in Implementation Science with Black communities based at St. Michael's Hospital in Toronto. He's received numerous honors, including a Canadian Rising Star in Global Health, the Excellence in HIV Prevention Award by the Association of Nurses in AIDS Care, and the President's Trailblazer Award by the National Black Nurses Association. And just a little editorial, we all love nurses, so you represent such a wonderful profession, particularly over the last couple of years. He serves on the editorial board of the Journal of Urban Health, as associate editor for the Journal of Adolescent Health, and associate editor for the Global Health section of BMC for Public Health. Professor Nelson has active research projects in the US, Canada, Ghana, lots of funding from NIH, CDC, Canadian Institute for Health Research. I'm not going to go on and on, even though I could. On a more personal note, I have to say I've gotten to work with LaRon Nelson over the last many years. I first met him when we both served on the New York State Ending the Epidemic Committee out of the New York State Department of Health and the AIDS Institute, and that grew out of the Governor's Task Force, which developed a blueprint and plan for ending the HIV epidemic in New York State. That committee that we both still work on has to do with helping implement and monitor the blueprint and the plan for New York State. And then more recently, over the last several years, I'm really honored to be a scientific co-chair with LaRon Nelson and Chris Byrer from Johns Hopkins. And the three of us are leading an HPTN 096, which is a new study in the HPTN. It's addressing Black MSM in the southern United States. Our goal, it's a community randomized trial, and our goal is to end the epidemic among Black MSM in the US. Much needed focus, much needed population. It's a very complex integrated strategies, community randomized trial. And I have to say, working with LaRon has been a pure pleasure. He's the glue that holds this group together. He's really highly energetic, and you can see from my brief intro that I don't know how he has the time, but he does it all. And LaRon, thank you so much for being here today, and I'm going to turn it over to you.
Yeah, Bob, thank you for that generous introduction, for inviting me here, both you and Teo. It's been an honor to know you and work with you too. I appreciate your friendship and the work that you're leading, especially through that center. So, I'm going to talk today about, let's see.
While you're getting set up, just a reminder to everyone, you can put questions in the chat during the presentation. There will be time for Q&A at the end, when you can also unmute yourself and ask your questions verbally.
Thank you. So this topic is titled, Awakening to an Intersectional Reality, Ending the Epidemic in the US Starts with Reducing Inequities in Black MSM. This is the title of an editorial that I wrote as a lead into a special issue that I guess edited for the Journal of Urban Health, which was focused on Black MSM, particularly because it was important for me, what I thought the world should know, at least in the United States, about what our strategy needs to be if we're going to be serious about the nation achieving its goal of ending the HIV epidemic by 2030, and what we needed to do to get there. And so this handsome gentleman on this that you see is not me when I was younger, but this is me when I was younger. This is probably, maybe I was a nurse practitioner by this point. Anyway, I had a lot more hair back then. This was my work in an STI clinic, or STD clinics, what we used to call it. Now, more often they're calling them sexual health clinics in places like New York and Toronto. But that's where my career started. And I spent a lot of time talking to patients and noticing things about patients and noticing sort of patterns. Maybe sort of the sleeping researcher in me always kept noticing patterns just before I'd gone to school to pursue a doctorate. But I was noticing all these things and that I would see among different patients, and sort of connecting dots around why were we seeing some things in some patients and other things in other patients who had different types of similarities, like race or gender, similar in those ways. And so I read this book, Discovering the Human Connectome, and it was a very interesting book because it talked about the ways in which connections influence, connections in the brain influence how the body functions. And so I was really fascinated with this idea of connections, how these regions of the brain that seemingly, we learned them in anatomy as sort of separate regions, but they didn't operate independently of one another. Something that happened in one part of the brain necessarily influenced something that happened in the other part of the brain. And I think beyond that, beyond my interest in connections in the brain, it was also how in which these connections, the way the brain was structured, influenced what humans could do, like how they could move their bodies. I was understanding that and making sense of what I was seeing and trying to understand what structures were influencing the behavior patterns that I was seeing among patients. And so this book really sort of set me on the path to understanding structure and complexity and being more sort of interested, maybe even consumed or preoccupied with structure and complexity, since it's really shaped everything I've done since those early days in that clinic. But what the book was saying was that an organism's behavioral repertoire is shaped by numerous structural and mechanical constraints, right? This governed what people could do, right? What behaviors they could do. But I think more importantly, or most interesting to me, was that it also governed their limits, like what they couldn't do, what it prevented people from being able to do, even if they wanted to. Those were limited by structural mechanical constraints. Beyond understanding structure, which is foundational in a lot of ways, it's still not sufficient to just understand how something is structured, right? What is the architecture? But what is it about the architecture that is influencing outcomes? At least in health, we're very concerned with, I'm very concerned with outcomes. So beyond understanding and investigating sort of structure and architecture of the brain or other things, it was also important for me, I was learning, important to investigate questions about these functional patterns. In health, I guess we look at them as behavioral patterns, how humans function. And so understanding where these patterns emerge, when they show up, when do they emerge, why these patterns emerge, and also how does the structure influence them? How does the way something is built influence why these behavior patterns emerge? And it's not necessarily how humans are built, but humans operate within environments that are built, right? And I'm not even talking about built physical environments. Social environments are also structured in particular ways that influence human behavior. And the nurse in me, the nurse practitioner in me, I think was at the end, was really understanding, if we can understand what these structures are, if we can map them somehow and understand how they function, then what can we do to intervene to affect them so that they can be more, we can engage them in ways that promote health and wellness, and I think also prevent illness. So this is just showing you the difference, right? In a sort of a dynamic way, and the utility of understanding structures, right? It's very important to be able to sort of see what this is, call it out, but also understanding how it works. It's not just sort of something that's sitting in the background, that in many ways structures in human societies and American societies are active, right? They do function in ways that have an impact on human health, even particularly in HIV. And so that was where my work began, is trying to understand structure and function. And I started this in Ghana. This was back when I was living in Toronto at the time. And this work was supported by Grand Challenges Canada. I think Bob mentioned being a rising star, Canadian rising star in global health. I'm not Canadian, but I was at least in Canada at the time. And this was work in Ghana where we were trying to understand the structure and function of social networks of men who have sex with men, right? At a time where people saying they don't exist, or you couldn't find them, there wasn't much epi on them, maybe no epi on them at the time in any serious way. And so we set out to understand, what are these social networks? How are they structured? How can we map them out? Can we characterize the features of them? But also, how do they function? How do they function to promote prevention? Do they function in ways that accelerate exposure to risk or exposure to HIV or other STIs? And then what are the implications for this structure and its function in terms of developing and implementing interventions that promote the outcomes that we were interested in, which was principally preventing HIV infections or facilitating treatment. This paper, the first paper is just describing what we did in terms of characterizing the structure and function, but this paper published in PLOS ONE was really sort of our first report about the implications of that. Like, what does it really mean? And what we found is that you really could predict behavior of individuals if you understood what how the network was structured, and other elements of that network. And then so it also helped us understand that if we could know those things, then we could design strategies that weren't just targeted at the individual, which can be inefficient in some ways, not ineffective, but sometimes inefficient, that we could design strategies that could target networks. Because if we could change overall the attitudes or beliefs or sort of social influences within that network, that would necessarily, based on these data, would show up and would manifest in what individuals did in terms of economies or HIV testing or linkage to care. And so that really started me thinking about these systems. How do multiple systems work, right? It's sort of all tracking back to this book I read about human connectome and thinking about connections. And so I was really interested in understanding how systems work in relation to one another. And again, I'm not just talking about physical systems or electronic systems, but just arrangements and the way things work. Everything's sort of arranged in different ways. So how do these multiple arrangements in societies work in ways that can either promote prevention or treatment or that undermine it? And so disconnections and misconnections were something I was very interested in. And then trying to figure out ways to promote cooperative functioning between systems, assuming that these systems are vital, that they're useful in some ways and positive ways in societies. How can we find ways that they'll work together to better improve sort of equitable outcomes for the people I was interested in studying, which in Ghana were MSM, in Canada too, I guess around the world I'm interested in studying MSM. But how can these systems work better that provide equitable outcomes for these populations? So this was more than a few years ago. This was data from HBTN 061, and what you see here is just data from the sample that was recruited from New York City. It was a non-probability sample, and there were 306 Black MSM recruited in New York. So across the top, you see a listing of what were called economic, social, and legal hardships. And then along the vertical axis, you see variables that were risk-related behaviors and STI incidents at 6 months or 12 months. So we were what I was interested in doing this analysis was understanding are there connections between these what represents systems, social systems, legal systems, economic systems, and behaviors. And so we'll just go through them. If you look at this, what's in this first red box, showing the prevalence of economic hardships. And I won't go through each one, but even if you just look at the first three rows, you can see that among the people who reported condomless insertive anal intercourse, like 76%, or almost 77% were unemployed, 82% had a recent job loss, and 83.5% had a financial crisis. It's almost all of them. It's almost a whole sample of people who reported that particular behavior experience this particular economic hardship. If you go down to number of male sex partners, so this is greater than 2 male sex partners in a 6-month period, I think. It's not bad, but it could be a proxy for potential exposure. So if you look at that, you see a high prevalence of folks who that applied to were unemployed, almost 80%, had a recent job loss, over 80%, and financial crisis. Almost all of them, right? When we did an analysis, we also found that the recent job loss was associated with condomless insertive anal intercourse. And a recent financial crisis was associated with having greater than 2 male sexual partners, almost twice as likely if people had a recent financial crisis. We don't know what that means because we didn't follow up to ask sort of these folks, what can you explain the connection between the two? But we speculated what might be some reasons that was happening, but there was definitely an association between these economic hardships and these behaviors. If we move on to legal hardship, so what we looked at in that study was history of incarceration and recent arrests. So you'll see the same pattern. If you look at condomless insert of anal intercourse, 78% of the people who reported that had a history of incarceration, and 82.4% had a history of arrest. Now, I think this was also, I don't know if it's even shown here. I think there was a variable about encounter with police, but these data were taken at the time where stop and frisk was policy in New York City. And it was extraordinary at how many people, just in a sample, a Black MSM had an encounter with the police. It was almost everybody. It was almost everybody. But in this, you can see for condomless and sort of anal intercourse, the prevalence of those folks who reported that behavior, who had history of incarceration, recent incarceration, or recent arrest. The same pattern you see for having greater than 2 male sexual partners. Most of those people had a recent incarceration or recent arrest. When we did our analysis on it, we also found that recent convictions were associated with having an STI at 6 months. And so when people came into the study, they were screened and treated if they had an STI. And so we know that if they had an STI 6 months later, it was one that was new. And so folks who had a recent incarceration, who reported a recent incarceration, were more likely to have any STI at 6 months, which was either chlamydia or gonorrhea, which will be tested for incident STIs. And then the last one was social hardships. And for social hardships, we looked at unstable housing and not having health insurance. And so I don't have to go through it because the pattern is the same. You see that for each of these behaviors and STIs, that the majority of folks, at least for the behaviors, reported unstable housing or no health insurance. For receptive anal intercourse, a little more than half of folks reported that had unstable housing. And for number of male sex partners, most people who reported that had these social hardships. And then again, we see in the bivariate analysis that unstable housing was associated with having any STI at 12 months. And so in 2012, PrEP was approved by the FDA. But even then, we had already started to see some signals from the very beginning that its impact would not be equitable across racial groups. And so there were a number of studies that were indicating that many Black MSM didn't even know about PrEP. And one of those studies, which is referenced here, was by Lisa Eaton. So Lisa and her team did a study, I think it was a survey study of 436 Black MSM in Atlanta. And what they found is that 20% of Black MSM had not heard about PrEP 6 months before the FDA approved it. Didn't even know what it was. And then 2 years after it had been approved by the FDA, that number had climbed to 23.5%. Not a very steep climb. And the results were not statistically significant, so we really don't know, don't have confidence that it changed at all. But in later, a few years later, the CDC, there was a study published in Morbidity Mortality weekly report that had a bit more promising news. And this was data from the National HIV Behavioral Surveillance Survey, which in their sample of MSM, they found that there was high awareness of PrEP among all MSM, including Black MSM, but that there were still disparities in the percentage of Black MSM who reported having discussed PrEP with their providers, and Black MSM had lower odds of PrEP use than white MSM. So this is interesting, and there's a lot of evidence to point to why this might be happening. Because if Black MSM are aware of it and Black MSM are interested in it, but they've not had it discussed with them by providers and they're not using it, it leads us to look for explanation as to why that happened. That might go beyond just focusing on an individual, but looking at the way systems might be impacting these behaviors that we're seeing or these observations. And so one study, very interesting, which was done by Sarah Calabrese, found that she did a study in medical students to kind of see what might be influencing differential PrEP uptake. Is it that folks aren't interested in PrEP, or that somehow providers are influencing this? So she did a study with medical students and found that they were less likely to offer PrEP for patients with the highest needs. So the patients who needed PrEP the most were the ones who were less likely for it to be prescribed to. And what they found is that there was this moral evaluation of sexual practices that was influencing what medical students decided who would get it and who wouldn't, like what this might lead some people to do. And so they were making judgments that restricted access to PrEP among people who needed it. And some of those patterns were patterns by race. I think the authors avoided sort of implicating race as sort of a driving factor. But when you look at the breakdown, there was a racial gradient in that breakdown of who they decided to withhold prescribing PrEP to. So this is related to what I just said. So in that study, they found that medical students rated Black patients, these were sort of composites, simulation of scenarios. They were more likely to rate Blacks as risky for condomless anal intercourse. And then that really translated to their decreased willingness to prescribe PrEP to those patients. And then this is interesting because this paper by Metzel and Hansen in 2014, where they really talk about structural competency and ways in which both medical students, nursing students, public health students are educated, misses the opportunity to help them also understand structural factors and the way structural factors influence behavior or clinical outcomes. And that because of this, that many practitioners view structural factors as personal failures or proxy for responsibility, right? So the poor patient, right? People think they don't understand, often appreciate the structural factors that drive poverty or that limit job opportunities or that constrain income earning, but see poverty or extreme poverty as an issue of personal failure and responsibility of the person to earn more or to do more. So this has implications for then how we decide to treat patients. This is data from a study in Toronto. It's a small data set, but it's illustrative in some ways. So I'm showing it. And this was from 20-something providers in various roles across 10 healthcare facilities that provide PrEP services. And so we were asking them about what influences, we were interested in how they support Black patients in particular decision-making about PrEP, including Black MSM, and what were some barriers to them providing sort of decision support for Black patients, helping them make decisions about whether this is right for them. And what they found was that, what we found among them was that for most of them, at least for nurses and physicians, time was a main barrier. Like they had other things accomplished, they had a certain number of patients they had to get to, and so they didn't have time to invest in supporting their decisions around whether PrEP was the right thing for them to be doing or not. And then many of them, but nurses and physicians, including there was one social worker, but across all of them, except for the one PA, they reported they had low capacity or experience working with Black patients. We also asked them about what factors would facilitate them providing decision support. And so, as you might imagine from what they described as barriers, having more time in the appointment was what the nurses and the physicians principally said would help them be able to better serve the needs of Black patients in particular. But some of them did say that they really want to enhance capacity for working with Black patients, which could include really understanding what factors are driving, what are the sort of, what factors are driving why patients sort of show up in ways that they show up, and then what can they do as providers to better address those factors if they can understand them, which leads to sort of education around structural competencies and how they can use that to better improve their practice. There was this is interesting, we did ask whether patients coming prepared with info, already coming in knowing what they need, would help. And so most of those providers that we surveyed did not think that would be necessary, but the only ones who did think so were physicians. We didn't probe what that might mean, but in general, that wasn't something that was expected. So we know what some of the barriers are, at least in this context, and this is in Canada, and what some of the facilitators are. But so it got me back to thinking about these systems, right? So I started out talking about how these connections are important, sort of being inspired by this book on the brain, but thinking more broadly about how the way our world is structured and how connections operate influence behavior. And so what I felt like we were finding, both from the work as far back as when we started in Ghana, to the work we had started doing in Canada, is that what we were seeing was that there were systems that were impacting what was happening. One was anti-Black racism, and not anti-Black racism as like interpersonal tensions between people, but anti-Black racism as a system, as a way in which the United States and Canada is organized in ways that privilege whiteness and that actively, deliberately disadvantage Black people and whatever gets characterized as Blackness. And in particular, how that intersected with system of capitalism in ways that obviously prioritize profit-making in the way that in which those two things came together, even in a clinic environment that had negative consequences for Black patients and for Black MSM. I mean, even among what we've seen in some places among providers who specialize in providing care to Black folks, that there is also, I'm not sure I would think of homophobia as a system, but maybe sexist systems that also disenfranchise men, Black men, who are gay or who have sex with other men, that don't conform to what service providers in Black communities think they should be. And so how that also intersects with the larger system of racism and capitalism to disenfranchise Black gay men or Black MSM particularly. So we thought we had to figure out we had to figure out ways that we can address this, because what we typically have been doing is really looking at behavioral interventions. How do we get individuals to do things differently? And there were limits to that, as I said before, to what individuals could do in a system that necessarily was structured with an architecture that constrained the possibilities of what they could do without having the ability to make extraordinary efforts. And so this is why systems, I think, are implicated, is because healthcare systems, healthcare settings are themselves social environments that have a structured influence on healthcare, also on HIV prevention and HIV care. And this climate is created by the people who occupy those roles that are structured into those healthcare systems, and those roles and how those people who occupy them enact those roles can have an impact on HIV outcomes. So my first work from this really was grounded in this theory called self-determination theory, which really addressed three things: autonomy, competence, and relatedness. And let's go back here. So according to this theory, these are three basic human needs. This is what humans need to thrive. Autonomy, which is the need to have control over the course of your life. Freedom to choose, freedom to be authentically yourself, and that environments that don't allow autonomy, that don't allow real options, real choice, that don't allow Black MSM to really be themselves, whatever that looks like, whatever that means, but that does not allow them to really be themselves, are going to undermine their ability to achieve health goals. Competence is the need to be effective in dealing with the environment. And some of that means that providers have to have a role in understanding what those needs are, and then contributing to the patient being able to be effective in dealing with the environment. Some of the issues they're facing are structural issues. And so to understand competence, to understand patients' needs is one important thing, but also being committed to figuring out what can we do as healthcare providers to address those needs, even if they're not clinical, even if they're not what you do in the context of seeing a patient in a clinic room, that there are other issues that are going to affect the outcome or the effectiveness of your treatment plan or your program or prevention plan with that patient or those patients. And then the last component is relatedness, which is the need to have close, affectionate relationships with others. This says relationships, you might call it connections, but the ability to feel like the person that you're going to for care actually cares about you. And that when you don't feel that connection, when the patients don't feel the connection, or when the provider doesn't pursue establishing that connection for therapeutic purposes, that it also undermines the ability for the patient to generate the motivation necessary to accomplish the goals, which many times involve pretty substantial hurdles. So this is just showing what happens when those three needs are met, that it influences motivation. Most people are not, unless for in a healthcare sense, if we were talking about something like condoms or PrEP, people aren't really intrinsically motivated for those things. They don't just like love condoms because condoms are so fantastic and fabulous and I just can't get enough of condoms. They do them for functional purposes. So they can still be motivated to it, but it's motivated for a different end, not condom use for the sake of enjoying polyurethane or that's not why. It's because they have other goals that the condom serves a need for. And that what happens is when healthcare environments can support people's freedom and autonomy, reducing pressure, when they can help clients or patients feel and be equipped to be more effective to accomplishing some of their healthcare goals, including tackling obstacles that they're going to face, many will face, and establishing authentic, genuine connection or relationships that can make this motivation move towards more integrated, which means they'll be able to take more time, invest more energy in trying to achieve those goals, which are important. Because as I mentioned, some of the barriers that people face are profound and in some ways can seem intractable. So this is just a couple examples I'll show you. This was a study we did in Ghana some time ago. This is actually that first CAPA study I talked about with Grand Challenges Canada. This was with people who were mostly HIV, who reported being HIV negative, 75%. Some were status unknown, but so anyway, mostly HIV negative from Accra, Kumasi, and Takoradi. This is a relatively young sample with the average age of 24 to 25. And so we use this measure called the Healthcare Climate Questionnaire, which is a measure of whether or not patients experience their healthcare facility environment as supportive of their autonomy, of their competence, and their need for relatedness and authentic human connection. This was used many times in many health domains, but up until this time, it had not been used to understand HIV prevention behaviors. And so what we found in this sample was that of all the things we looked at, STD knowledge, HIV knowledge, sense of community, stigma, both HIV stigma, gender nonconforming stigma, that healthcare climate questionnaire, that's that HCCQ that you see in that red box, had the highest associations with condom use for all sexual behaviors, for oral sex, for anal sex, and for vaginal sex. So it's a very powerful predictor of patient behavior. But the HCCQ is not about what patients are doing. It's about what the healthcare system, what the environment are doing, and how that influences, how that can show up in patient healthcare behaviors. And these are health promoted behaviors. These are things that in many instances we want patients to be willing to do. And the healthcare climate has a major influence on that. So this is another study from Ghana, but this is a sample of men who have sex with men who are living with HIV, recruited from 4 cities, mostly from Accra, Kumasi, and Takoradi. But in this, what you see here is association between the healthcare climate and retention and care, such that people who reported high ratings on the healthcare climate were 1.63 times more likely to be retained in HIV care. So both for prevention and for treatment outcomes, the healthcare setting, the influence of the healthcare climate is very important. So this is going to talk about some work in the US now, but also it's in the same frame. This is an image from HPTN 073. And if you can guess from the taglines, my life, my health, my choice, this study was grounded in self-determination theory, which was about how can we address these intersecting issues around Black gay men who experience homophobia, who experience racism, and in a healthcare environment that can address these intersecting issues around the autonomy, around these structural factors that interact with their identities, that come together to undermine their ability to reach their prevention goals. In this case, we're most interested in PrEP because the study was looking at PrEP uptake among Black MSM. So what we found is that during the study, 178 of the 226 participants initiated PrEP. We thought that this could happen over, let's say, a 6-month period. This because PrEP rates in the US were so low at that time, so we had planned it would take some time using this approach for Black MSM to start to be interested and then start using PrEP. But it did not take that long. 68% of the people who enrolled started taking PrEP at enrollment, right? Immediately. When we use these principles, autonomy, competence, and relatedness, that on the first opportunity to take PrEP, which was at study enrollment, 68% of the people took PrEP. And it was only 25 people, or 11%, took PrEP at a later point. So out of all of the people in the study who took PrEP, most of them took it. At the first time they were offered, it did not take extraordinary effort. It only took us to be willing to address these intersecting issues in the healthcare environment. And in this sense, we're talking about clinical research sites, but they still operated with these principles. We also saw that among the participants who initiated PrEP, that 64% of them, almost 2/3, met the criteria for this 90% sensitivity threshold that showed that they were taking PrEP at least 4 pills per week, right? And then the analysis, and this will be coming out in the paper soon, showed that the healthcare climate was associated with long-term adherence for PrEP among Black MSM. And these cities were, oh gosh, Washington, DC, North Carolina, I think Chapel Hill, North Carolina, and Los Angeles, California. And so we started to figure out how to implement this across New York State. So we did this in 4 communities: Brooklyn, Buffalo, Queens, and Rochester, in a way to more quickly figure out how can we take research information and translate that into practice, which is another way that we're going to have to get used to doing as researchers and clinicians working together if we're going to have an impact. It can't take 20 years to translate research evidence into clinical practice. And so this is our attempt to really try to move what we had learned from HPTN 073 into public health and clinical practice. And so now, really what I'm trying to advance is for the nation, that was the whole point of the special issue, was to think about multi-level intersectional approaches that really can address the complexity of lives with Black MSM and the way that these systems are connected and how can we design interventions that can influence those connections. It's not simple or easy to do. I think it can also be hard to get funded, but I think it's what needs to be done. And so that was really my plea to the nation. And so what you're seeing here is a study that is happening now in New York City, principally. It's based in Brooklyn, but including from across the boroughs. This is leveraging family-based assets for Black MSM and houseball communities. This is an intervention study that is designed to promote PrEP use among Black MSM who are part of houseball families. So this is the model that we use, which is looking at not just individual behavior, individual risk, but how then do we look at how families as a system, right? Individuals interconnect with families to promote resiliency that can buffer against intersectional stigma and other hardships that Black gay men, young Black gay men in New York face. This was especially influenced by what we learned from HPT 061, which really outlined the various economic, social, and legal hardships that Black MSM face. And so instead of just focusing on how do we reduce risk, we looked at what is happening in these environments, what structures are constraining these men's ability to achieve these outcomes, and what can we build? And we use families, these families as assets, and thinking what can we build as assets to help the men overcome not just barriers to condom use, but the hardships, right? Because condoms don't protect you from being stopped by the police and arrested, or condoms, landlords don't take condoms in return for housing. And so we had to find other ways to address those things that we know were associated with these behaviors, or these outcomes that we were trying to reverse. This is just showing a design. So we really were trying to take an intervention, which was many, many, many voices, and redesign it into what we've called Our Family, Our Voices. So that was based on conducting formative research and then conducting a pilot cluster randomized controlled trial with houseboat families in New York. It's been hard to do with the pandemic, but we at least did do the formative work and are now preparing to do this pilot trial with families in New York. The other example is a study called PRISM Ghana. PRISM is actually the name the NIH gave the program that they funded, promoting reductions in intersectional stigma. So we use that, we retain that, but we're doing it in Ghana in collaboration with community and government partners. And what we're doing in Ghana is really taking three interventions and addressing them together. So one is called Yansipo. Yansipo is a behavior intervention, but it is based on many, many, many voices. And it was one that we adapted for use in Ghana some years ago. We're using it because it showed that it was resonant and relevant in the Ghanaian cultural context, but it already had evidence for efficacy in increasing condom use and HIV testing. We use a peer support network intervention. This is based on this model by a friend of mine, Cindy Lee Dennis, which is about how do we use peer networks to support empathy, education, and empowerment. And so this is Hive 3. So the 3 E's are empathy, education, and empowerment. And so this intervention is when each peer is trained and can provide this type of peer support, emotional support, informational support, and really, especially in Ghana, support that affirms their humanity as relevant. It's hard to even think about what they're going through, but to really affirm their humanity of Black MSM in Ghana that's almost always under assault, especially in this current political climate there. And then the other intervention, which is at a different level, not behavioral intervention for the men that we're targeting, but this is intersectional stigma reduction in healthcare facilities. And so again, if you remember what I said for a few moments ago, this is how we target change in the healthcare climate by addressing stigma at the intersection of HIV stigma, homophobia, and gender nonconforming stigma. And what we hope will result in changes in how providers, and not just providers, how healthcare workers in those facilities engage and interact with MSM in Ghana, but also how they might restructure policies or practices in the clinic that themselves also marginalize MSM who have to go to these places for care. We're doing this in 8 clinics in Ghana, both in the Ashanti region and Greater Accra region, using or collaborating with both public and private clinics, government clinics and private facilities. And this is our theory model that we're using, which is if we're gonna try to promote, in this study, the primary outcome is HIV testing, Like if we're going to do that with MSM, we have to do more than just intervene with MSM to get them energized and motivated to test. That we have to also influence the environment where they have to go for the test. And so that is the whole reason we're doing this multi-level approach. And then we're facilitating engagement of the MSM to these clinics, at least the clinics who are randomized into our intervention arm, in hopes that what we'll see is that a greater willingness of the men who get Yansapo and Hy3 to get tested. And among those who get tested in our intervention clinics, that you'll see that they report fewer reductions in stigma and higher frequency of testing over time. But again, this is a complex multi-level, it's not even the most complex one I'm going to talk about, but this is an approach that I think matches the complexity of the challenge. So this is just showing our design. So again, just like the study in New York City, we started with the formative approach to really know and understand how to make this most relevant to the local dynamics, both culturally, socially, and political dynamics in the communities and in the healthcare facilities. Because it means we're working with people who don't necessarily love, appreciate, respect MSM, but they are the gatekeepers to the care. And so we have to find ways to reach them with an intervention as well. And then the last study I'll talk about is a study that I'm very proud of and pleased to be working with Bob on. You see his name there with the three stars. He should have got 5 stars. But this is HPTN 096. Its title is Getting to Zero Among Black MSM in the American South. And this is testing the efficacy of an integrated strategy. So we've designed this study in collaboration with many community and government partners. You can see the list there. Community partners, advocacy groups, Black AIDS Institute, nursing organizations, as well as the NIH, who is a funder, and our collaborators from Centers for Disease Control and from HRSA. And so this is sort of, in some ways, given the story I've told you so far, sort of a little bit full circle, because it's influenced by a lot of what we've learned from my work in Ghana, but also from the other co-chairs' work with MSM in a recent study that they led, which was HPTN 078, which is, we know that in the center of this circle, you see biomedical interventions, PrEP, ART, and testing. So we know those work, but they're not having the impact they need to have on Black MSM. And we know, and I sort of tried to show this in this talk, some of the reasons why, that there are social and structural as well as behavioral challenges that are constraining the ability for the Black MSM to benefit from these clinical innovations. And so what we try to do is develop a strategy that can better make that a possibility. And so this includes 4 intervention components, again, multi-level. It includes a health equity component, which really is about engaging service providers across sectors to sort of not even re-engineer their services, but find different ways to cooperate or align their services or create synergies between the services that they provide to better have an impact or better reduce the barriers that Black MSM have to testing for PrEP and ART. Peer support, which Dr. Remien is leading which is really being able to provide that type of emotional, affirming, and information support to Black MSM that aren't tethered to where they go for care. If they go anywhere for care, that they should be able to have access to peer support. Stigma reduction or intersectional stigma reduction at healthcare facilities. And then social media influencers, which is designed to really influence larger social norms, because all this stuff happens within the context of a larger social norm or attitude around Black MSM. That includes attitudes around race, how racism is manifested, attitudes around HIV, and attitudes around gender nonconformity, which I didn't talk a lot about, but this idea that Black men are also marginalized if they don't enact roles that people, Black people, white people, people in general, think Black men should adhere to based on what the notions of what an appropriate masculinity looks like. And then if we do these 4 components of this integrated strategy, that we can see an increase in HIV and STI testing, And then once we know who does not have HIV, that this can help support the uptake and adherence to PrEP so that we can increase the proportion of Black MSM who are protected from HIV. And then among Black MSM who are living with HIV, they're using this strategy, we can increase the uptake of ART, increase and support adherence to ART, and then increase the proportion of Black MSM who are virally suppressed and thus unable to transmit HIV. So these are happening at the community level, and then outcomes that we're looking at are also at the community level, which is unusual. It's not studies that NIH typically does. It's not the type of work that we typically do in the US for Black MSM, but I think it does represent this need, this sort of willingness now to recognize and understand the way that this epidemic is complex. The factors are multi-level, and that our interventions need to match the complexity of this epidemic and the things that are driving it. So we're testing this in a trial, a randomized controlled trial with 16 communities across the South. And so the randomization just happened yesterday. And so 8 communities are in the intervention arm and 8 communities are in the standard of care arm. We're right now starting a pilot phase, but the study will have a 3-year implementation period. And then we'll look at outcomes. We'll look at some interim outcomes. We'll look at them in the interim, but also at the end of the implementation period. And what we're really looking at are rates of viral suppression among Black MSM, which we're going to get from data, surveillance data from the CDC, and prevalence of PrEP use among Black MSM, which we will get from some assessment that we'll do as part of the study. And so let me say this idea of surveillance data, right, is important too. And I'll say this in my concluding slide, but I think in the research world, in HIV research, I think we have to be concerned with impact, right? And when we did this study and we designed it this way, it's really heavily influenced by Chris Byer, who's an epidemiologist down at Johns Hopkins, that it needs to be designed in a way that we're not just going to have some findings at the end, but by the time we have findings at the end, we want to have used that time to really make some impact. And so we're not just going to be able to see if a sample that we followed over time change, but we'll be able to look at CDC surveillance data, and we hypothesize that this intervention will have been so impactful that the surveillance, it will be manifested, it will be observable in the surveillance data. These are the communities where the study is going to be done. They're paired, so you'll see these colors that are similar are the communities that are paired together. And you see in this box with some of the things that we considered when we thought about how we paired them. Some of these communities have very nuanced, different structural and social challenges, but that's what the integrated strategy is designed to really try to impact the way that those challenges intersect to undermine Black MSM's HIV goals, and then obviously undermine the nation's ability to reach its 2030 goal for ending the epidemic. And so, in summary, these issues that intersect to really, I think, drive the inequities that we continue to see in HIV among Black MSM, that make it difficult for these biomedical innovations to have impact. We know that much of it is social and structural. Whether the systems are social or the systems are physical or environmental, that they do work in ways that undermine Black MSM's ability to achieve prevention goals. And so, because if we know this, then the interventions that we design and implement have to be matched to meet the complexity of these social and structural drivers. Racism is itself an operating system. It's not an attitude, it's not a belief, it's a system. It's how we are organized, just like our system of capitalism organizes how we understand and execute labor in this country. We accept capitalism. I think we also accept racism. That's a problem. And racism intersects with other issues like homophobia, HIV stigma that further marginalize Black MSM. So we have to figure out ways to address that. It is an overarching issue. It is everywhere, it's in everything. not because everybody is racist, but because racism is an operating system that governs US human and power relations. Risk reduction by itself is not sufficient to ending this epidemic. We have to figure out ways to leverage community assets to address some of these social and structural drivers. So it's not just about reducing risk. We also have to figure out how we identify, leverage, and build assets in communities that support Black MSM. And that the research let me say it slowly. The research must help the rubber meet the road. It won't be enough to just make discoveries. I think we have to be more focused on how do we implement this? How do we make impact happen? And researchers can study it. Researchers should be doing it in collaboration with clinicians who know more, I think most about implementation. But we can't do the study and make it wait for somebody to figure out how to implement it in real life. We have to be figuring out ways to do them both at the same time because it is urgent. This is life. And I think we all want the country to reach its goals, but we don't want Black gay men to continue to be left behind in that pursuit. So thank you. And I hope we have time for questions, but I appreciate having the chance to talk to you about that.
Thanks, LaRon, for such a wonderful presentation. So just a reminder to everyone, if you have a question you'd like to ask, you can type it in using the Q&A feature at the bottom of your screen. Or if you'd like to ask your question directly, you can use the raise hand feature also at the bottom of your screen, and I'll unmute yourself. So first we have a question from Brian Kuttner. This is a fabulous set of studies. What could you share about what you're learning about how to reduce intersectional stigma, including the successes and the challenges?
Yes, so I think what we are in a couple different ways. I think what we're finding is that people's, at least in the healthcare facility, which is where we focused, is that healthcare providers, an advantage that most of them really want to be helpful. Like they aren't really trying to be intentionally stigmatizing. And so there really is a lack of awareness of the ways in which their behaviors stigmatize people. And so I think when we can do that, it creates an openness. So that helps with stigma reduction. It makes them more willing to figure out how to change their practices, especially if we can reduce defensiveness. Because when you tell anybody that they're doing something to stigmatize people, that I think we do see this immediate defensiveness, because I think you're calling into question people's personal integrity. So we try not to do that. Some people could be intentionally doing these things, but we try not to do that, to say, listen, some of what you do might be creating these situations that stigmatize, and here's how. And so not that you're intending to do it, but this is what happens. And this is what means for your patients when this does this, which always is interesting because they do want to improve patient outcomes. They want to do what's best for patients. So helping them understand how their behaviors are stigmatizing, how that influences patients, and how that actually means that they're providing worse care than they would want to provide has been helpful. Another way is this idea of facilitating contact between the stigmatized group and the patients. In healthcare facilities, not all, but in many places, the only understanding of Black MSM is as their patients. So all they ever hear from them is the problems. Here's what I went through, here's my symptoms. And so that besides what they see there and what they might see on TV, like that is the limit of the understanding of who these people are. And that influences what they think about them. And so having a different way to have them have contact with the patients to understand the diversity of experiencing small Black MSM, to understand what some of the factors are that might influence what they see and why they see it is also helpful, but it's facilitating a different way to have them to have contact. Because many of them don't have contact with them in social settings. They don't go to church with them. They're not in the same schools. They don't go to the same social clubs. And so that means that their understanding of them, how to deal with them, is only influenced by the clinical presenting problems. And if that's the only portal within which you can view a human or any human, you can imagine what that might lead you to think whether you want to or not, about who you think they are, and that influences care as well. So those are the two things that I think we've seen have been really useful in reducing intersectional stigma in healthcare facilities. Oh, Stephen, you're muted.
Stephen, you're unmuting me to respond.
Yeah, if you'd like to.
Yeah, I was just typing my response. I was just going to say that's such a helpful point about the positive function of contact, but that it varies depending on the context of the contact. Like if people are only seeing the problems, they're only encountering Black gay men in the context of some healthcare problem, then that's really limiting the positive function of that contact. That's such a useful point to make. Very, very helpful. Thank you.
You're welcome. Thank you for the question.
Are there any other questions?
Stephen, I don't have a question, but I would like to make a comment.
Sure.
LaRon, it's fascinating to see how you start with your book and still it inspires what you're doing now, and that it's such an arc. So it starts with ideas, and the ideas are getting very practical now, and really will have impact. It's really wonderful to see, and thank you for sharing that, and thank you for sharing that is that kind of journey. That is really beautiful.
Yeah, thank you. You know, it took me a while I didn't connect the dots, but I think it was a mentor who got frustrated with me and said, you think like, why are you stuck here? And that sort of made me realize, I think everything I do is like based on this book. But I mean, that can be a challenge too, that you see the world as only a series of connections and disconnections. So I try not to do that, but I think if I'm being honest, it has sort of been a theme of my work ever since, even up until now. But thank you.
And the other comment I want to add to that is that it's fascinating to see that you're able to get grants looking at structural interventions. We are talking about that in the center to see how can we make that work, because we also feel like that should happen. We should go beyond the individual, beyond the group level. We have to do much more than that if we really want to have an impact. And it's inspiring to see that it is possible and that you're doing it.
Yeah, I think even especially now, I mean, with this current administration who's set up an office and has a senior advisor for equity, who I talked to yesterday, who's really saying, you know, this is real. Like there is momentum to figure out how we do this. And so I think this is a time where these proposals might get traction, whereas 5 years ago or 6 years ago, they may not have even been thinkable. I think there's an opportunity to do this type of work in collaboration with both communities, biomedical scientists, and social scientists, who I think have been saying it for a very long time, but have not been taken very seriously.
Stephen, good, go ahead.
Along those lines, if I can jump in, you know, I mean, first of all, LaRon, you know, such a tour de force and such a great body of work. I mean, it's, you know, kudos to you. And so, yeah, thank you. But, you know, I mean, community mobilization is something you've talked about, you know, and you started there, and social networking, and you know, your last ending comment was about maybe this is a time of, you know, where we can do more structural or system level things, but also I guess I'm just inviting you to say more. I mean, we know in what the work we're doing in 9/6, the fundamental importance of the community being engaged and mobilized to put the programmatic things forward that we're talking about. But, you know, I'm just inviting you to expand a little bit on that notion of community mobilization and where we're at right now to be able to do that better.
Yeah, you know, I think that I think the communities already have the answers to the problems, right? And I think if I'm being honest. I think a lot of what needs to happen is about politics. We can create all the evidence in the world. We already have a ton of it. And the issue is, how do we get people to move resources or change policy to make that happen? And I think researchers can have a role in that. I think partnering with communities can help us demonstrate that if we can get an opportunity to show, look, if you change these things, right? Because sometimes evidence really can help people make compelling cases to policymakers or decision makers. But I think at a point when there's enough evidence, that community mobilization can do a couple of things. People can already start make micro changes in their environment. So they may, that's all we talk about is cooperation, right? It doesn't require you to say, hey, we need Kaiser Permanente or some other health system to change. Like, you know what, everybody, y'all have your jobs in these places. What can you do even on the micro level, at a local level, to organize or work together differently that addresses these issues? And so when communities can mobilize, even if the larger systems don't change, I think they can do things that can really help address some of these barriers. I think the most efficient way would be to have larger social change, but it doesn't have to happen that way in order for things to happen on a local level. In Ghana, for example, we spent so much time trying to get these guys to go in for care. I mean, they would not do it. There were people who were dying. I was saying, man, listen, these symptoms you're having, like your viral load is high, this is really bad. And he said, I'd rather die than let those people treat me like they treated me. He wouldn't go. And so we had to say, listen, is there a different way? Why do these guys don't want to go? It's traumatic, it's triggering. Even the memory of it is causing people to sort of react right in front of us when we're asking them about going to these places for care. And so we said, is there a different way to do it? So talking with some of the community members and the nurses, said, can we build something where the guys can still get access to services without having to show up? I mean, we would call that telehealth now. My light just went out. But so we designed this app. We call it Auntie's Corner. It was basically a nurse coaching app, which allowed people to report their symptoms for the nurse to be able to review it. And then if they needed to come in, they can make contact. But the goal was, we have to reorganize the system. Like, we're trying to get people to engage in a system that has barriers, that has history, that is not simple to ask people to ignore, right? Oh, forget about what happened last time. Just come on back, which is what we were doing. And so we said, okay, we're not going to change the Canadian health system, but we will design a strategy, sort of a workaround to figure out how to get people access to care without having to always go into the clinic. What we were able to do, and this was through community saying, hey, there's this new app called Auntie's Corner, you can use it, I used it. It was able to pattern a series of good experiences, right? So the guys would say stuff like, I'm gonna go out and have sex with 100 guys, and what should I be thinking about? Because they're expecting, okay, now this nurse is gonna say something about how Allah or Jesus frowns upon that. But we did it. We said, okay, here's what you say, right? Here's what we know work, condom use, but if you might want to have lube. So the guys were shocked that, whoa, I said this to this nurse, and instead of her sort of bashing me over the head about this behavior, which they might think was extreme, they said, okay, if that's what you're going to do, let's think about ways that you can, reduce your chance of getting an infection if that's not what you want to get. And so over time, it patterned these good experiences where they thought, well, maybe I can engage. If they came to a point where they needed to re-engage. But that was the work of communities figuring out the solution. It didn't occur to me that might be what needed to be done. And so I think the answers are already in these places. And that's what that's sort of another way to think about how we do it. I think in the meantime, while we're trying to get large level policy change, there are already things that could be done, but those things usually need to be resourced. And I think that is the challenge. That's sort of the way I was talking about the way capitalism sort of comes in. Because unless they can identify some revenue generating strategy to be self-supportive, they have to find a way to be able to support doing those things. So Ghana is an interesting place because I've been able to do a lot more in Ghana ever been able to do in the United States, even though Ghana has a lot less resources than the US. But I think how they understand these things are very different.
Thank you. I always love your perspective on things like that. Thanks for sharing all that.
Theo, were you going to say something earlier?
Yeah, LaRon, talking about Ghana, how do you think about what's happening there now? I'm not sure if people on the who are participating in the rounds now are aware of what's happening in Ghana. Can you say something about it and how you expect that that will affect your work?
Yeah, well, it is affecting the work. So right now, there's a bill in the federal government in Ghana that essentially criminalizes gayness, same-sex behavior, same-sex identity, even sort of allied support to people who are LGBT. And so that has created a sort of national conversation about it. They have tied it to HIV, so sort of implicating the behavior as the main driver of HIV, which is an interesting way that they've taken evidence that has said, they looked at HIV risk and prevalence among key populations and say, look, here's the consequence of doing these things. And so it has made it more difficult for us to address the intersectional stigma in healthcare facilities. I mean, there's one facility now, I'm not even sure. I mean, we did a lot of strategies, and so they actually did finish the intervention, but it really is, people are afraid, right? Like if they engage in this conversation, what does this mean for their jobs, especially the folks who work in the public clinics that we're working in? The MSM are afraid to gather. I think part of this sparked off was there was a group of paralegal training, and I think it was mostly sexual minority women who had attended this. Maybe there was some trans men there too, but so they had been arrested and held for over 30 days. And even if they weren't charged, I'm not sure anybody was convicted, but it doesn't even matter. In Ghana, if you're arrested for LGBT anything, like you're done. Like your reputation is ruined, your chances of economic growth is ruined, you might get kicked out of your apartment. I mean, it is terrible. So now people are, they ask us very detailed questions when we're recruiting them because they're worried about what happens if the police raid Yansipo. I mean, what is that going to mean for me? And that we can't really protect them from that. I will say, Taylor, you remember I was in Ghana, but that's part of the reason why I needed to go, just because we said we need somebody, an American, somebody who can run some interference long enough that if we needed to come up with a strategy or get some lawyers in or get some people out, that we could do it. But it's making it much more complicated. Our only saving grace is that the people in Ghana know how to manage it, and so we're following their lead. So it slowed things down, but if we got to go slow, we got to go slow. But it has made it much more complicated, and most of it is about safety and people's concern about whether or not if they engage in this type of work or try to change their practice, if they're seen as sort of being in violation with sort of the national consensus that LGBT life is incompatible with Ghanaian life. So it's tough.
Thanks.
I will say too, I guess I know we're just at 11, but one of the things that we've done is, people don't say it, people are not going to get on television and say, I support LGBT rights. Maybe they will soon. But, we work with people in government and the police force who may not be supporters of LGBT rights necessarily, but they're supportive of human dignity and respect. I think people should all be treated fairly. And so we finished one city of Yansipo with police protection, right? And we're doing it in Accra right now. I think we're doing it like right this minute, they're doing it. But we organize networks of people. We have lawyers on standby, we got nurses nearby, we got transportation. We're saying, listen, hopefully nothing goes down, but if something goes down, here's what we have to do. And so again, it's about how do we identify and leverage these connections that allow people to participate across sectors, but in ways that also don't expose them to social risk. Because if they were found to be participating and helping us, they stand to lose a lot too. But
that's really, really remarkable that you're thinking ahead and that there are plans in place to address the issue if it gets worse. That's hopefully it doesn't get there.
hopefully, so far so good.
We've reached the end of our session and there are no other questions in queue, so I'll turn it back to Bob.
Okay, well, I'll just do a simple. We're very grateful, LaRon. Dr. LaRon Nelson, thank you so much for such a fantastic presentation, thoughtful discussion and dialogue. And I continue to learn a lot from you, I think as we all do. And thank you for gracing us with your presence today. And I will be seeing you very, very soon. Take care, and we hope to see everyone on September 30th for our next rounds. Thanks.